prefer to see it.
Hi, everyone, and welcome to our July ambassador briefing. We are lucky to be joined by Dr. Velma Scantlebury, who will speak about the transplant process and answer questions from the crowd. And so when she is done, I will talk about our local education events, and then we'll have our usual Q&A time after that. So without further ado, I will turn it over to Dr. Scantlebury. And Dr. Scantlebury, just to start it off, just to let you know, in the past, we've had folks who have had lots of different questions about the actual transplant process of how does the kidney make it in, and what's done on a physical level to make it work for the new person. And then also some people have had questions about the wait lists and how do you, are there any tips to getting on? Some people question as to why you have to hit certain kidney function levels to make it and things like that. So I'll let you take this briefing in whichever direction you like, but just wanted to give you a little bit of a heads up.
Well, thank you so much. And it's difficult for me to, because this topic covers such a wide area of information, I'll try to hit on the highlights and make sure the questions get answered. And so it becomes important to understand that, I'm sure you guys understand how to get on the list. The best way to get on the list, the goal when we think about transplantation is certainly the fact that there are just not enough kidneys out there. So some centers focus on telling patients, bring your donor with you, your potential donor when you come, to focus on living donation, so that you can avoid the wait list. And the goal is from area to area. The wait list is years, 10 years, 12 years in places like New York or California, while other places may just be a year or two. So the goal really is to think about, is there someone who can donate to you? Because that's going to be the best way to avoid the many years of wait list. Certainly there's a difference in patients who get diagnosed early and those who get diagnosed late. So if you think about a disease process that you already are on track with because your doctor's aware that you are in stage 3 or 4 and is going to head towards dialysis, then you have the advantage over someone who was not diagnosed in time and now is in stage 5 and need to go on dialysis. And so oftentimes those patients are told, oh, you need to go on dialysis instead of, you can think about a transplant, but if it's 6 months down the road, you may not have enough time to really think about the whole process. And the whole shock of having end-stage renal disease, for many patients, they're only majority of time told about dialysis. Those who are in the stages of knowing, let's say you have nephrotic syndrome or polycystic kidney disease, and you are on the path to know that you will end up with kidney failure, then that preemptive opportunity is a real advantage, because patients who receive their transplant preemptively are at a much greater advantage, because one, they are not suffering the consequences of long-term end-stage renal disease, which as your kidney fails and you go on dialysis, having kidney disease puts you more at risk for underlying heart disease. So the longer you are, we know that patients who are on dialysis for 10 years compared to those who are on dialysis for 3 years compared to those who are on dialysis less than a year, we know that there's a difference in outcome. And so if you do better, the less number of years you're on dialysis. So preemptive transplant may only go, if we had an ability to screen and know everyone coming down the pipeline, then they can be prepared to say, okay, I might need a kidney in a year or 2 or 3 years. Let me optimize this. Let me think about living donation. Let me learn about the modalities, which one I want to do if I'm over the transplant age, so I can do better with this option of dialysis as instead of hemodialysis being given as the #1 treatment. So we know that the sooner you get on, they used to say, the sooner you get on the list, the time is of the essence. But now that the list is focused most on dialysis time, you want to, if you've been on dialysis 10 years and you now decide that you are out of access and you want to get a transplant, then certainly you will get 10 years of dialysis points, which may cause you to jump ahead of anybody else who would have been on there for 5 years or 6 years. So if you're preemptive, or if you're early on and you don't have a donor and your EGFR is 20% or less, we will get you on that list so that you can continue to occur time, even though you may not be ready for a transplant. Because if you don't have a living donor, that time on the list is essential, but we're knowing in our head that perhaps you're not ready for a transplant because you're still doing well. And why is that important? Because we want to look at the risk benefits of transplant. So if your EGFR is 20 or 19%, and your blood pressure is well controlled, you don't have any problems with fluid retention, your phosphorus is not a problem at that time, your potassium is not a problem, and you're still working, or when I ask you, so what are your symptoms? Your fatigue is not terrible, you don't feel any different, and you are doing well at that EGFR of 20 or 18 or 17. Our goal is to be able to say, even though you may be accumulating time, unless a kidney comes down the line that's absolutely perfect match, the issue is that we want to be improving your quality of life. And so if your quality of life is excellent and you're not on dialysis and you're doing well, unless it's absolutely too good to give away a kidney, we're going to sort of say, well, let's wait for something else, especially if it's the age difference, if it's a kidney where the patient kidney may not work right away, you might need to go on dialysis and you don't have an access, you're not ready for access. We know that the surgery itself may push you towards dialysis if that kidney doesn't work and you're gaining a lot of fluid. So for many patients, it's how you're doing versus the type of kidney that's being offered to you. And does that make sense? Does anybody have any questions at this time? Okay.
Well, so I just want to interrupt real quick and say, I am reminded I did not give you a proper introduction. Want to let everyone know that Dr. Scantlebury was the first African-American female surgeon in the country and also has performed over 2,000 transplants. And just want to make sure everyone is aware of that, so you know exactly who we are lucky to have been joining us today. But so Dr. Scantlebury, so we had a question from somebody before when they said, you know, they got the transplant and then their kidney did not wake up for a little bit. Can you talk about the actual science of what that actually means?
Okay, well, great question. So we will take kidneys based on what we feel is a predictable outcome that this kidney will still do well. And you can have, there are different types of donors. So I'll give you a simple one, and that is you had a very young, healthy 30-year-old who was involved in a motor vehicle accident or a trauma, something like that. No underlying disease, no underlying hypertension, diabetes. But because of tremendous blood loss, just say they fractured their liver and the spleen had to be removed and they had to be resuscitated. And there was a tremendous run of events medically. And so that person had a lot of blood loss, their blood pressure was low, they had to be resuscitated. And as a result of all that, the kidneys suffered an event because of, you know, when you get dehydrated and blood loss and you get hypotension, you're not going to pee much and the creatinine may go up. But now that they've gone through that, they're not recovering. The head injury was severe and now they're going to be a donor. The family has agreed to organ donation. We know that creatinine is now high because they were dehydrated. So once their consent is obtained and they're declared to be organ donor, then the OPO will work to give the patient enough fluids to try to get those kidneys to creatinine to improve. And once they start making urine more, the creatinine may still be high, or they may make urine and creatinine may still be up there. So a kidney like that was suffered events during the resuscitation. We may tell the patient, this is a great kidney, a great opportunity to recover, but this kidney may still suffer the shock of the events that occur. I mean, we put the kidney in, and that kidney may have good blood flow, but they will suffer from what we call ATN, a slow kidney, because of the events related to the donor. And in those cases, the goal is that, especially also the time it takes from coming out of the body, if it has to be transported, it's sitting on ice, it's coming to another center, and 12 to 24 hours occur. And now we will call that a slow kidney. So we may say the patient, the kidney may not make urine right away, so we'll dialyze you until it opens up. And gradually that kidney may make 10 cc's an hour. It may make, 120 cc's a day or 200 a day. And gradually it would go from making nothing to making more. So it may take days. Most people take about a week to 10 days to open up. Some people open up in 2 to 3 days. If it doesn't open up by about 2 weeks, we'll biopsy to make sure there's no underlying rejection. But until that patient gets to at least a liter a day, then they're able to come off, then we're able to hold dialysis. We will hold dialysis to make sure that we give the kidney a chance to recover. Now, there are donors who will be not able to be declared brain dead because they still have brainstem function, and that brainstem function, even though they have a cerebral injury, the brainstem is still sending messages for them to breathe and to heartbeat to occur. So what happens in those patients is that the family, once the neurologist said there's no evidence that this person will recover, they will become what's said to be non-brain dead donors. Also, so we can't declare them brain dead. The family's wanting to donate. So we'll take that patient to the operating room. We'll disconnect them from the ventilator. We'll prep and drape and have them ready to go. We step out the room as a surgeon. The family comes into the room and the patient's disconnected from the monitors, and they're allowed to stop breathing on their own, which will occur faster than the heart rate. And so in those situations, we will have a delayed recovery. And the reason for that is that a delayed response of the kidney, because even though the heart's beating and it's going from a pressure of 120/80 to 100/60 to 80/20, that may take half an hour. It may take 45 minutes. We will wait until an hour, some places an hour and a half. But even though you have a heartbeat, you have no oxygenation because they'll stop breathing at about 5 minutes or less. And so now you have a kidney that hasn't received oxygen for quite a while. And so that will lead to non-function. If the donor is young, those kidneys will recover, but that dialysis period may be slightly longer. So we'll say, yes, we can use non-brain dead or cardiac, after cardiac standstill. You have to wait until they're flatline. They're then declared dead by another physician. The family leaves the room, and we quickly open up the patient, take those kidneys out and put them on ice. So those will take a while to open up, and we'll make sure those patients are young and healthy, because that's much more of an insult, because the lack of oxygen, the cells in the lining the tubules of the kidney will die off, and then they'll have to repopulate. And that also takes about 4 or 5 days.
Mhm.
So
go ahead, I'm sorry.
So I was going to say, those are the two major instances. Sometimes we'll take a kidney that looks great. A lot of it has to do with the donor, how the patient died, how they were resuscitated. And oftentimes we predict the kidney will do well, and it doesn't make urine right away. A lot of that has to do with depressors and all the medications that they're on in the ICU prior to being declared.
And another question we got, it says, with some of the recent changes and news about UNOS having alternative agencies, how might it help or not help various folks waiting on kidney transplant or waiting to be listed in the future?
One of the issues that unfortunately, when you look at saying that units need to be taken over by other agency because the current one isn't doing the job, because the whole area, the whole arena is being criticized because there are lots of organs being wasted. You have to, one of the concerns that we have is that many of these alternative agencies that are being proposed are for-profit agencies. And when you begin to put a system in place that's out to make money, then you have to remember that the way things stands here within transplant, it really should be nonprofit, because everybody makes money from the donor process, except the donor, the potential donor, the donor family. Whether it's the OPO, those recovering the organs. If you're a for-profit, then you're driving the bandwagon. And how is that going to affect patients? I think, you have to look at the end result, because the goal in mind is that as we talk about the fact that there are organs being wasted and you want to do better, it's also about what's in the best interest of the patient. If you're recovering organs, then they're very yes, you can take a liver from a 75-year-old or 80-year-old and give it to a patient, and then people are upset because the kidneys aren't being used. But an 80-year-old kidney doesn't have a lot of longevity for that patient who waited 10 years to get a kidney, and then you're giving them a kidney that may not last 6 months. Is it fair to that patient just to say you haven't wasted a kidney? Because if that patient goes and get a kidney, doesn't work by a year, he is lost. He has to go back and wait. He doesn't jump in the line again because that kidney didn't work. You have to decide that by 3 months. By 3 months, you're not quite sure if that kidney is going to open up or not. So it's the advantage of, when you say kidneys are wasted and we need a better system, the OPOs recover kidneys that have cancer in them, and they spend hours and hours trying to place those kidneys. But who wants a kidney that has a cancer in it? Why did you take it out to begin with? So we got to learn to maybe leave things alone and not take kidneys that you know people aren't going to take. But then the system gets criticized for wasting organs. But I have to sleep at night, and I'm not going to do something if I know it's not going to, for the sake, well, I could take it out in 3 months, or I can take it out in a month or two, just for the fact of saying I'm going to use it. So it's those kind of things that really we can't talk about. But you hear people talk about, well, we need a better system so we don't waste organs. Sorry, that's my bandwagon. I'm on my platform.
So another question is, can you touch on some things in recent changes regarding transplant listing assessment impact traditionally racial disadvantaged population listing and wait times?
Yeah, one of the things as we talk about with listings is that even I was just, doing some charting on some patients, and in the current systems that are still lagging, although the major ones have changed, is the elimination of EGFR and using the race factor. And so one of the issues with that is that when you list patients for transplant and you're African, you can take an African American and a Caucasian patient of the same size, body weight, height, and creatinine, and you calculate the estimated glomerular filtration rate. And if you put in a factor, the same, they have a creatinine of 1.8 and everything else is equal, there's a race factor that goes into that equation that will cause that African American to have an EGFR of 24, but for the Caucasian, the EGFR will be 18 or 19. So now that Caucasian person can get listed for transplant. The African American can't because he's over 20. And so by putting that race factor in there, it has denied many patients the ability to get listed, and they've wasted many years with off the list. So what's happening now, by eliminating that race factor, many transplant centers have to go back and recalculate without adding race, because your kidney disease has nothing to do with whether you're black or white or green or yellow. So why should there be a race factor that says if you're black, you get minus points, and if you're white, you don't put these points in? And so patients are now able to get transplanted, because if they thought they had 6 years on the list and you add that rate, go back and recalculate, now they get an extra 2 or 3 years of waiting time, and they can become, much more competitive in getting transplants. So in talking to some patients, they were able to move upon the number of years they've had and get transplanted. So that becomes important. So when we think about patients and getting transplanted, the list is really about waiting time, your blood type, and the amount of antibodies you have and your underlying factors. If you look, so if you look at patients who are difficult to transplant, would be those who, even though they have many years, they may have antibodies, and those antibodies may be from a previous transplant. They may be from previous exposure to any foreign tissue, and for many women, pregnancy. So with every pregnancy, multiparous women, they have antibodies that have to do with having been exposed to DNA of the children's father. And so for many patients, so if they're waiting for the 3rd and 4th transplant, they may have what we call as a PRA of 100% or over 95%. And what that means is that 100% of their antibody, 100% of their genetic material has antibodies directed at donors. And so they test them against a random pool of donors, and we say 100%, if all 100 of those random donors react to the serum of this potential recipient. And so some of the labs were changed. You have people who, if you're at Jefferson, they may pool the blood of even the people in the lab, random people, and collect their serum and see if these transplant patients react. Those make them very reactive. So those patients get extra points because the goal is for them to be at the top of the list after children, so that they can get tested for every single potential donor that comes down the line. But we know in those patients, if they may get tested over and over again, but they come up with a positive cross match, and so therefore they don't get called in for the transplant, because they show that they still have that transplant that they're tested against still is going to be positive, which sets them up for more rejection. So, one of the things we talked about is also choosing how do you select a donor, and certainly for someone who is a first transplant may have many more options than someone who is a 3rd transplant, because that 3rd or 4th transplant have many antibodies. So we would know that this patient will more likely have rejection. Like for instance, we use pediatric kidneys. So let's say we usually try to give them to people who are not too obese, because these kidneys are generally, just very small eggs. And we may use both of them together, but they may not have a lot of cortex compared to one single adult kidney. So if someone is more likely to have rejection, we will not give them small pediatric kidneys, because there's not enough cortical material to withstand the rejection. And those kidneys will burn out faster. So there's certain things we may not use. So if you are a young person who is 20 or 30, I'm not going to put a 60-year-old kidney under you. I may have a difference of about 20 years, 10 to 20 years, depending on the donor recipient gap from that standpoint. If you have a long history of diabetes and have multiple complications, I may take a risk and use a kidney that may have some underlying diabetes and high blood pressure, high blood pressure and some scarring, even if it's less than 20%, because as a diabetic on dialysis, your mortality is much higher. So getting off dialysis and using a kidney that may give you a creatinine of 1.8 to 2 or 2.2 is going to be much better than sitting on dialysis for the next 5 years. So those are kind of the things that we go into our mind in terms of saying, what is the longevity of this kidney and this recipient, and what is this going to offer this patient? Certainly a kidney that will give someone 5 to 8 years is better served for someone who may be, over 70 than someone who is going to be in their 30s and 40s and may need 3 or 4 kidneys to get them to a certain age. So those are the decisions we make there in terms of offering. Sometimes kidneys are being offered and they usually start with the local area and offer them out. Oftentimes the offers you get from outside of your area, maybe it's usually because wherever it's coming from already turned down that kidney. So my first question is often, well, why are you offering me this, and why is it not being accepted in the local area? And you want to know, well, the biopsy is not so good. Remember, on a frozen section, immediate analysis of a kidney, it's usually about 25 to 50% underestimated than the final section. So if someone calls and says, I have a kidney that looks like it's 18 to 20% scarring and my limit is 20%, oftentimes the final comes back more like 40 or 50% scarring. So it's like, okay, what you see on a frozen section biopsy may not necessarily reflect. So now you've given somebody a kidney that have 50% scarring, and you go, okay, the longevity of that isn't going to be long. So those are the things that go into say, well, this will benefit someone who is in his 70s and may do better off of dialysis, because when you look at the longevity off of dialysis reverses your heart disease deterioration, better control of your blood pressure, better control of many things, so you'll do better, even though it may not be necessarily a great kidney.
Sure. And is it true that if a person gets a transplant and it fails, they go back to the top of the wait list, or is there a time frame where that might apply?
There's a time frame that it applies. It has to be within the first 90 days. So if that kidney doesn't open up by 90 days, they can get back in line, but and not lose time. But generally by 3 months, most kidneys are making some urine. It may not be great. And oftentimes you'll hear, OPO say, this kidney was turned down by center A, B, and C, but center D accepted, and the patient is making urine. It doesn't tell you what the creatinine is, because some people still make urine while they're on dialysis. And sometimes they'll say the kidney is making urine and it's functioning, but now the creatinine is 7 to 8. Well, it's sort of functioning. And you're hoping that may last the patient a year, but at that time, if they wait past 6 months and it fails after 6 months, they have to start all over again. So you have to make the decision early, otherwise the patient loses their position in the line.
Yeah. And does getting blood transfusions affect your transplant?
Yes, they do. So the goal really, we tell every patient who comes to us and is contemplating getting a transplant, or get on the transplant list, you can get blood transfusions, but you have to tell them that it need to be filtered blood, CMV negative filtered blood. And so most transplant hospitals do that automatically for all patients, because but for many patients who live in rural areas or smaller hospitals, we have to tell them, keep in mind, you're on dialysis, you have chronic anemia. Granted, nobody should be getting blood transfusion except it's a trauma, an emergency. The dialysis center should be on top of your hemoglobin, giving you erythropoietin to keep you from being transfused. So many dialysis patients get these transfusions because no one is monitoring the hemoglobin, and they at increase in the dose. So maybe they were resistant to one therapy, they should switch to another. But if they're chronically anemic, the automatic knee-jerk symptoms with patients who are newly diagnosed with end-stage renal disease on an acute basis is that they're severely anemic, unless it's less than 8 and jeopardizing the underlying heart disease. They should, give them iron infusions, do the remedy, RNS, Procrit, whatever it takes to increase their hemoglobin.
And how long does it take?
Oh, let me finish that. And so the result of not using a filter is that you get red blood cells themselves have no antibodies on them. It's the other stuff that seeps through the transfusion, such as your macrophages, your platelets, your dendritic cells that get through, and they will then cause the body to react and make antibodies. And so those antibodies with multiple blood transfusions of unfiltered blood will then raise your antibody level to the DNA of those donors. And if you have multiple donors, you're going to have a whole slew of antibodies directed against your A, B, and DR loci that we monitor for transplant. And therefore, it's going to make that's going to make you more reactive.
Sure, thank you. And another question from someone is, how long does a transplanted kidney last from a living donor? And what are factors that influence this, assuming the recipient is in otherwise good health?
Yeah, so what when you think about living donor, certainly the age of the donor matters, and the size of the donor in terms of that standpoint. So the older a donor gets, the longevity of that may be compromised. So you have a 30-year-old getting a kidney from his 66-year-old father. That's going to say, okay, if that recipient is a male and he's muscular, his body and his creatinine is going to be higher. So that he may end up with a creatinine of 2 after transplant, because that donor, even though at that age, you want to make sure that his EGFR, oftentimes it has to be 80 or greater. So if he's a muscular donor, he may make the cut, but it's still going to be a 66-year-old kidney. And so he may get 5 years or 7 years at best if he squeezed many years out of it. But the idea, because in such a situation, the parents are saying, I want to donate to my son. And you go, okay, everything is okay as long as the son understands the longevity. But if he's diabetic, you'll go ahead and do it, because certainly for a 38-year-old, you said, well, you may need another kidney before 10 years down the line, or you might get 10 years out of it. The goal really is that the younger you are as a donor, the healthier is going to be that kidney. That kidney is going to be. And secondly, living donors do better because I'm taking that kidney out. I'm not storing it on ice. That's traumatic to deceased donors, but I'm going across the room and putting it in a person immediately within the first hour. And that kidney, you take it out, you watch it make urine, you give them Lasix, you make sure it's making a lot of urine, and squirting up and down, and then you take it out, you put it in, and you can see that it's going to make urine. So a kidney that works right away makes a big difference than a kidney that has delayed function. And a living donor, you have to remember, we're using a donor that has no underlying heart disease. They shouldn't have any significant atherosclerosis, and those arteries should be well open. And that's the issue with an older donor, is that you may actually have some plaque disease or atherosclerosis within that lumen of the kidney that you're using, or even into the kidney itself. And that comes with age. So you're going to have capability of having less glomerular function in an older kidney than an younger kidney. So for the average younger kidney, the goal is to be able to get 15, 20 years out of that kidney, but everything else has to also line up. They have to be compliant. If the more rejections they have, the more damage occurs over time. The more infections they have, BK virus, CMV, all those set patients up for cutting time off their longevity, as well as underlying antibodies. So if you're a living donor, you have underlying antibodies starting out. Some people also develop antibodies after their transplant and post-transplant donor-specific antibodies that somehow they were not a problem prior to transplant, but now something's activated them. And now after their transplant, boom, they've got antibodies that now crept in, and those can become a problem in the longevity of that kidney also.
And what causes someone to be able to get multiple kidney transplants? And some folks feel discouraged when they feel like they can't even get one and they're on dialysis for years.
Absolutely. The system isn't necessarily fair to that, and the system is blind to whether it's your first, second, third, or fourth transplant. Certainly for most people, it's because they started young. and their first transplant was at a certain, a teenager or even younger than that. And the goal with each transplant is that you're being followed by that transplant center is to really delay the onset of that end-stage renal disease and to get you listed before you hit dialysis. So I know your kidney is failing and you're at a creatinine of 4 point something. I was like, well, let's get you back on dialysis. Let's get you back on the list, even though you're not going to get transplanted until it really becomes until the option is obvious that that's what we need to do. Why do people get a retransplant? Generally because the underlying chronic rejection, the body, unless you get an identical twin, you will need anti-rejection therapy. And so I tell people your kidney is like a car. You can buy a new car and it can do great, no problems. You maintain the maintenance, you get it inspected, but you got to always make sure that you're visiting, getting your lab work done, checking to see what's out of order, checking, what we now call cell-free DNA to monitor what's going on with the kidney. But you can buy a new car and have it not last 5 years because it's a lemon. And nobody recognized that. But you can also get a used car, which may not be great because someone said, oh, why would you buy a 5-year-old, 10-year-old car? But that car may last you another 10, 15 years because it was in good condition and you took care of it and you didn't have any problem, no accidents. Every time you get an accident to a car, it does a little bit of damage, and the more accidents you have, the less longevity. So I said that's like rejection. Rejection is often subclinical. We want to make sure that it takes a while before it reflects in your creatinine, which is why most centers now are looking at cell-free DNA. That really gives you a detection there's something going on in your body. We know that there's DNA being released from the donor tissues. It may be infection, it may be rejection, but it occurs much earlier than a change in creatinine. So those things are important. Ultrasounds to make sure you're not having a stenosis at your anastomosis, evaluating kidneys to see what can I do to prevent that onset down the line. Biopsying to see what's the degree of chronic rejection is there. Maybe you're too much cyclosporin causes chronic rejection. Maybe I need less of a calcineurin inhibitor and more of another medication to help have better longevity in that kidney.
Thank you. And what are some things folks should do to stay healthy while waiting to be listed or waiting to be transplanted?
Goal is that while you are waiting, the longer you are on dialysis, the things we want to see is lack of progression in your minimal progression in your underlying heart disease. Fluid status is very, very important. One of the things why I advocate, for people on PD and people on home dialysis do so much better because they're able to filter their bodies, they're able to keep that fluid status under check, and they don't, because they're, if you start out, you may even have some urine output while, with PD, and so that allows for a better balance. When you're home dialysis, even if you're not making urine, you're cleansing your body on a regular basis that minimizes the trauma to your heart. So you're waiting over a long weekend, you dialyze Friday, you're not dialyzed into Tuesday, you gain 10 or 15 kilos. Let's say 10 kilos. People say 10, but in our minds, we don't think, what does 10 kilos look like? That's 22 pounds. Just imagine your body, your heart having to deal with that extra weight. So what happens with 3 days a week home dialysis, you have much more deterioration in heart disease. And so think of your heart as a yo-yo. You take off the fluid and you put it on. You wait 3 days and you take it off. And so you then squeeze in and expand in your heart, and you end up with underlying, cardiomyopathy, and you end up with underlying issues with your heart. So the mortality of patients with dialysis really is about trying to control your fluid status. If you're not making urine, maintain, because that heart disease, you come back to us and now you have severe valvular disease, you have your heart's big and floppy, you're unable to maintain or have a good pumpability of your heart. And in some of those patients, when your cardiac function decreases, certainly if it's less than 20%, we're not going to transplant you. When you're 20 or 35%, the question is, will transplant improve that? And we've seen some patients who, despite transplant, still can't pump that fluid off. There's still edematous, the kidney is functioning, but it's not seeing enough fluid because the heart can't pump, and we have to dialyze the fluid off. So what's the point of getting a transplant if your heart isn't able to pump better? So we want to make sure that underlying disease from even just having, whether you're diabetic, hypertensive, and chronic renal failure can lead to certainly worsening. So you want to maintain that. You want to make sure you've seen your cardiologist, getting your stress test, and echo if you're diabetic, or transplant centers are continuing to monitor. Stay free of infections. And make sure you let your transplant know if you have any peripheral vascular disease or leg problems or urine infection, because you come in for a transplant, they're going to send you home. So it's better to be aware and to inform them about what's going on with your body, control your weight. So those are the things I focus on, because most times we bring a patient in and they haven't had a stress test or the echo in many years, and it's like, oh, anesthesia says, I'm not putting this patient to sleep, I need a recent test. And then you then have to scramble to get one, or you cancel the case.
And there's been some articles over the past few months about how in Europe the rate of transplantation is higher. Can you talk a little bit about maybe why more kidneys or higher percentage of kidneys are being transplanted in Europe than they are here?
Well, the population certainly is, and the health of the population is different. I think in US, we have so much obesity and underlying chronic disease that a lot of our donors are not necessarily ideal. And so you're picking, choosing from the quality of organs because of our issue with chronic obesity, hypertension, and diabetes. Certainly, when you look at that, and the selection process may be a lot different. Certainly for many countries, their focus also may be on living donation. Certain parts of this country, Minnesota and North, have a different population of people than inner cities in terms of those who become donors. And so the underlying denominator is so much different in the United States in terms of the health of the patients versus those in Europe. So people are a lot smaller. They don't have as many underlying issues, and I think that certainly affects the donor pool.
Oh. And what happens if you need to send a patient home before surgery? Does the organ go to the next available patient in the area?
Yeah, generally the OPO has the list. It may not be the same center. Oftentimes it's a different center, unless you are the only center that agreed to accept this kidney. And oftentimes a kidney may be offered to a certain area, and let's say 5 transplant centers say, nah, I don't want it. And you're the only transplant center that says, I'm willing to take a chance of it. Then you may go ahead and bring in your 2 patients so that they're in the hospital in case one doesn't work out. Then you don't have to wait to bring the second one in, but you tell the second one, you're just here for backup. It's 50% chance or maybe 80% chance you'll go home. But if the first patient cross-match comes back positive, especially for someone who has a high cross-match, a high antibody level, and you want to continue to get that kidney into the body as soon as possible, you may choose someone who does not need to be dialyzed that day, and who can get there sooner, and who is not a high antibody person as a backup, so you can go ahead and put that kidney in, because the longer it sits out waiting for a patient to get to the transplant center, the less likely that it will work right away also.
Sure. And what are some key metrics / indicators kidney patients or care partners can learn or understand to know if a kidney offer is right for them, or do people just accept whatever is offered?
I tell patients, and oftentimes, I think about where I have been in 3 different OPOs and 3 different transplant centers, and it goes from centers not telling patients anything except saying, I have a kidney for you, come on in, to centers where the coordinators, where you say, you can tell patients, everything about the kidney that you're able to, except for what do we say? And maybe the age, we don't do specific ages. We give just in case people live in certain areas and it's a potential donor from the same area. We may say patient is in their 20s or 30s or somewhere between 30 and 40. But generally, if you are diabetic, you want to be cautious about accepting the kidney. Is the donor diabetic, or how long have they been diabetic? Or if they're on insulin, you're on insulin, that may not be a good combination because that donor may have underlying kidney dysfunction that's not recognized before the biopsy. Certainly one of the things you also realize is that the way kidneys are categorized by the computer is sometimes the all or none. And even for high risk kidneys, the computer, you are said yes to be high risk if it happened within the previous 12 months. So some patients may say, I don't want a high risk kidney. And I said, well, high risk may mean this patient had a blood transfusion. But that's not necessarily a bad thing. So check yes to high risk and then go through the algorithm. A patient may be high risk just because they've been put in jail for a DUI 11 months ago, because check, have you been in jail? Yes. And suddenly go, I don't want a jailbird, but it's still a good kidney. Regardless, if someone is in jail and have been in jail for 20 years, I don't know, and you're worried about infectious diseases, or they've been a prostitute, those are different high-risk categories that you may say, what kind of high risk? So understanding the risk, patient may be high risk because they're hepatitis C. And so that becomes important to know, because that usually they offer you a hepatitis C kidney with the understanding that you're aware of the fact that you may develop hepatitis C, but it's also a way to get a kidney and be treated for hepatitis C. So that's patients will say, well, why, take a hepatitis C positive kidney. You can jump the list because many patients don't want a hepatitis C kidney. And that allows you to say, granted, the understanding is that we'll treat you after when you develop hepatitis C, because the medications can only be given once you are documented hepatitis C. Not everybody develops hepatitis C, but it does. Remember, when we test a donor for hepatitis C, we're saying this donor has antibodies against hepatitis C. Often the time to donation doesn't allow you to check to see for virus itself. It takes a little bit longer. So asking questions, there's nothing wrong with it. Some programs are open to it, and others say, you don't need to know that stuff. So I think it's the patient's choice, and the more you know, the more you have to be comfortable with what you're getting. And other patients say, doc, if you think this is a go, then I'll go with your decision.
Great. I think we'll do last question here. When patients or care partners are looking for potential living donors, should folks disqualify those who are interested based on minimum maximum age besides health issues?
No, I don't think. I think you should let the transplant center decide the disqualification. Oftentimes family members go, oh, I'm not a good donor because of A. I'm not a good donor because don't do that. Oftentimes allow the transplant center, because people will say, well, I'm not a good blood type, but you want the transplant center to evaluate you because you may not be compatible, but you may be willing to go into a pair exchange to allow for your recipient to get a kidney, even though you may not be directly able to donate to them, as long as that you're okay with that. And another donor, another place may be willing to accept you as a donor from that standpoint. So oftentimes, if a donor is turned down at one place, there's nothing wrong with getting evaluation at another transplant center. So for recipients, you may get recipient center may not be willing to take the risk, but another more aggressive transplant center may be willing to do it.
Cool. Thank you. And so I would like to sincerely thank you, Dr. Scantlebury, for all your insight and advice you were sharing with the group today. It was a very enlightening conversation for me, and I learned a lot. So I'm sure everyone else did as well. So on behalf of everyone here, thank you for your time today, Dr. Scantlebury.
Hi, Kyle. How are you? Nice to see you. And thank you guys so much for having me. I know it's a lot of information. If there are any other questions you have, and so much we didn't cover, you're jumping around, but I'll be happy to come again.
Sure. Thank you very much.
Thank you.
All right.
Take
Bye-bye.
care.